Good evening, everybody. Welcome back to the living room. I am beyond thrilled to see so many people in the room tonight. We so love to be able to bring this to you guys, a place where you can not only learn about the different aspects of navigating your disease and treating your disease, and but really kind of come and be with one another. And I know I always have to kind of wrangle you to come and away from the mingling around the table and the drinking of the wine or water, whatever you choose. But I really appreciate everybody. Hello to everybody online. Thank you so much for signing in. Please, 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 if you haven't signed up for the chat and you would like to chat, to ask questions of our speakers, or just to talk to my beautiful sister Andrea, who's sitting at the table moderating, please sign up.
Your younger sister.
Yes, my much younger sister, Andrea. Yes, which we have to. Every time I say something about my sister, it's always like, well, she's younger. And I'm like, yes, I know how old she is. But we have a great evening planned for you guys tonight. Kimberly Parham's all the way out from Nashville, Tennessee. Not only does she have a lot to talk to us about tonight insofar as nurse navigation, but what nurses can do to help you through the process, as well as some of the other services at your community or academic center that you don't even know is available, and what an important role they all play. So we're really excited to get to Kimberly and her talk, and she's got an amazing accent, so she's really fun to listen to too. What we're going to do tonight, since there are so many people in here, is I'm really going to ask that for those of you who do want to do introductions, and I think it's important so that Kim knows who she's talking to really just keep it to your name, your stage, and your date of diagnosis. I was diagnosed, this is my name, this is when I was diagnosed, and this is what I was diagnosed with. That way we can really get around the room and then come back. And then as questions are being asked, as everybody knows, it's free for all. Ask questions as they come up. We aren't holding questions till the end. As it becomes relevant, we can tell a little bit more about your story as it might pertain to the question that we asked Kim. But I think given the amount of people, we aren't going to have time for lengthy introductions today. So I don't know, Jim, if you want to... Just go to Neil.
Just go to Neil. We always start with Neil.
And don't forget to grab your mic. There are some new faces in the room tonight. Welcome, welcome. A lot of you who we've talked to online, either on the phone or over email. So I'm really, really excited to meet some of you tonight. So thanks for coming.
I am Neil, and diagnosed 3.5 years ago. Stage 4+, non-small cell lung cancer. And just want to thank everybody for last month indulging me in my little presentation that I did. And I have the honor to go with Bonnie next week and talk with a Lilly company on all of our behalfs. So I will be doing that and hopefully representing you as best as I possibly can.
I think right now the best has already come and passed. So I'm here tonight with my husband Jim, and it's a pleasure to be here. So I'll pass this on.
They've got their own over there, sweetie. You don't have to get up.
Yeah, you're good.
Okay, yeah, okay.
My name is Candace Fitzgerald. I was diagnosed with non-small cell lung cancer, stage 3B, in March of 2014.
I'm Eric Carmichael with Celgene. We love partnering with the Addario Lung Cancer Foundation. Just they're a great organization. You guys are very inspiring to me. That's why I love coming to these things.
That's my new boyfriend.
Sally's a cougar. Sally's a cougar.
I'm Sally. I was diagnosed in February of 2009, so I'm almost 6 years. Non-small cell adenocarcinoma. I had surgery. It was staged at 1A.
My name is Tina, and I was diagnosed in November of 2010. So I'm past 4 years. I have 3B adenocarcinoma, and I've been on Tarceva now for 3 years, and good scan so far.
I'm Rick, Tina's husband.
They've got one.
Hi, my name's Larry, and I was diagnosed in July of last year. So relatively new to all this. I'm stage 4, small cell lung cancer. So that's about it.
Oh, hi, I'm Janice, Larry's wife, and I'm here. And we're very curious to see if there's anyone else that has small cell lung cancer and any other research, clinical trials regarding it. Thank you.
I'm Doug, and I was diagnosed in July of last year, and I have stage 4 non-small cell lung cancer.
Hi, I'm Cookie Rodolphi, and I'm here to support my brother, Vinny.
Hi, my name is Vinny, and I was diagnosed October 30th with non-small cell lung cancer.
Hi, I'm Rosemary. I was diagnosed a year and a half ago with adenocarcinoma, non-small cell lung cancer. I started out as a stage 2B and graduated to a 4.
Hi, I'm Mary Basso, and I was diagnosed in October 2010 with stage 4 adenocarcinoma, non-small cell lung cancer.
Hi, my name is Nikki Martin, and I'm with Genentech, and it's my first living room, so I thank you for welcoming me here.
Let's give Genentech a round of applause.
Yeah. Well, and Celgene, they have an amazing drug for squamous as well, correct? And when you get to Clovis, they've got a second-generation TKI in the pot, so all good.
Okay, hi everyone. My name is Linda. I'm mother of my daughter who was diagnosed with stage 4 lung cancer in November of 2009. She's been on and off various drugs, but she's now on Tarceva and doing quite well with it. She's back to teaching full-time, and she's got a 6-year-old boy by herself, and she's just marching forward. So one thing at a time, and she's handling it. So.
And where do you live?
I live in San Diego.
And where did you drive up from?
I drove up from San Diego.
Crazy.
So, you know, whenever you think to yourself, oh gosh, I live in San Jose, I'm not going to drive clear over there. Linda's driving from San Diego, so you guys can drive from there. This is the best place to be and to come. Our son was living in San Francisco at the time she was diagnosed. He found the group, and they've been part of our family for all these years. So, hooray for the Addarios.
Oh.
Hi, I'm Chris Harrison. I was diagnosed 11 months ago with same thing everybody else has, stage 4 non-small cell lung cancer. And everybody tells me I look great. So
you do? You all do.
Yeah, it's so far, it's all working. Thanks to you guys.
Hi, my name is Tekla. I was diagnosed just before Thanksgiving of this year with stage 4 adenocarcinoma, and I'm very grateful to be here.
I'm Pat Moser, Tekla's friend from Santa Barbara. I drove up from Santa Barbara.
Nice.
And this is really awesome.
Hi, I'm Christine Ott, and I'm here on behalf of my mom, Noreen Ott, who lives in Sacramento and was diagnosed in February of last year with stage 4 non-small cell lung cancer.
My name is Laura Rubin, and this is my sister, so our mom is stage 4.
I'm Suzanne Roy. I work at Clovis, and I've been conspiring with Hank for ages to come to one of these. He fills me in regularly because I live and work out in Colorado.
Hi, my name is Homa Yaganiki, and I work at Clovis. We're so proud to be here. Thank you for welcoming us, and we look forward to very close partnership with you all very soon.
Hi, my name's Robert. I was diagnosed with stage 4 non-small cell in May of last year.
I was diagnosed with non-small cell lung cancer stage 4 on October 26th.
Of last year, she said. Oh, is that right? Okay. Hi, my name is Jane Hilliard. I was diagnosed August of 2011, stage 4 non-small cell adenocarcinoma. I find it very hard to believe I have lung cancer because I feel so good. But thanks to Bonnie, my husband found Bonnie in this group, and they're wonderful. I do want to say one thing. I know I'm not supposed to talk a lot, but I've been on Avastin for almost 3 years, which my oncologist said is very unusual. Usually only lasts maybe a year, year and a half. So I attribute that to part of, I think, homeopathic medicine that Bonnie also introduced me to. So I'm very happy to be here.
I'm Reed Hilliard, her partner, and I was diagnosed with fear and anxiety in August of 2011, and Bonnie and Danielle and the team here cured me. Thank you.
Hi, I'm Betty Corner, and I was diagnosed with adenocarcinoma oligometastatic, and I had surgery. I had my lower lobe removed on January 12th of this year, so this is day 8, and I feel great.
Wow. You go, girl.
I'm Mike Corner. I'm Betty's husband. I'd like to add to that the pathology report came back clear.
Yay.
Is that everyone?
So before we jump into the program, I'd actually like to ask Jane and Rita a question because they are chronic live streamers. They don't get down to do this very often, and I guess I would like you to let the people know that maybe feel like they can't make it down here how it is signing in online. Like, what's your experience with the online portion of this program? This meeting.
Okay,
That's
well,
okay.
I'm the one that normally signs in. So, and we both watch religiously. It's not quite as good as being here, but it's a darn sight better than not having it at all. It's been extremely helpful to us. We just can't, we're about 5 hours away. We can't get here. And the education we've received, the support we get by tuning in is just phenomenal. To the point where we are the official advocates for the Bonnie J. Addario Lung Cancer Foundation in Northeastern California now.
Nice. Lake Amador.
And we pass around the 360 binder often to people that need the help. So it's been very helpful to friends of ours, so we appreciate that too. Thank you.
You know, to that point, I'd like to just mention, just to the pharmaceutical people that are here tonight, you can find a breast cancer support group on every corner. You can tell now by hearing that people are driving up from San Diego and Santa Barbara, Lake Almanor, Santa Cruz. This is a very, very unique thing, and that's why we started live streaming it, because we thought this is such an amazing night that we have once a month, and we couldn't possibly put one on every corner. It wouldn't have been financially feasible, but to live stream it opened up a world of opportunity to patients like you in the world. We get people. We've reached 143 countries, so big shout out to everybody dialed in. We love you. Come see us in person.
And although I'll thank them at the end, we couldn't do it without the support of,
Absolutely.
of industry and private donors. I do want to point out to everybody in the room, again, I know I've thanked you guys time and time again for sharing what we created here as sort of this private little, safe place with the online community. It's one of the reasons I wanted to kind of get some feedback from Jane and Reed, because I don't know that we thank you guys enough for sharing this. Because it's not always easy, and it's somewhat intimidating when you come and you see the cameras in the room. But the benefit of your generosity to the people who can't be here, and what it brings to them online is huge. So thank you so much. And to the supporters in the room, and by that I mean people who have in the past and or may want to sometime in the very near future, and that's Clovis and Genentech and Celgene's for supporting this program. Really patting yourselves on the back for the work that you're doing, because without people like you out doing what you were doing, A, this wouldn't be possible for us financially, and B, a lot of the drugs available to these patients that are sitting in this room today wouldn't be there. So may they be a constant reminder for why you do what you do, because it's oh so important. And with that being said, what I would like to do is, you guys all have the Kimberly's little flyer in front of you. So for any of you who are who haven't read it, please do. It talks a little bit about who she is and about nurse navigation. I will tell you that I first met Kimberly, Scott and Andre and I actually, when we were out visiting the hospital that she works for, which is St. Thomas out in Nashville, Tennessee. And what I can tell you is that their lung cancer program and what they have built and what Kim was an integral part of building is one to be reckoned with. I mean, it's a model that needs to be replicated over and over and over in every community center, that it's possible to do it in. And I talk about them all the time when going out and looking for centers of excellence. And they were one of the first to sign on with us last year. So we're really proud of our partnership with them and amazed by what they're doing and what Kim is spearheading over there. So with that, I don't know, Kim, if you want to say anything and introduce yourself before I start bombarding you with questions, or if you want me to just bombard away.
Well, let me start with what nurse navigation is and what we have within our system and how we got to where we are. Several years ago, there was a utilization review that took place in hospitals and insurance companies that made sure that you had so many days you can stay in a hospital. And then there were case managers that were in the hospital units trying to make sure that you were discharged okay with what you needed. And out of it, while that was going on, then there was Harold Freeman in Harlem who was going, we see better results with patients who are really really taken care and brought in to get screened and get early diagnosis and then have the support to follow them up with their treatment, they have a lot better results. So that was going on while all the utilization review and case management was going on, and then it kind of got to where it got married and the nurse navigation kind of came from that. So what we really try to believe and try to work with explaining other physicians and other hospital members, even within our teams, is that navigation has several phases, and we like to think of making sure the appropriate screening happens at the appropriate time so that an earlier diagnosis can be made. So we take from initial screening or symptoms to when a diagnosis is made. We want to reduce any amount of time in removing barriers. And then once a diagnosis is made, till treatment is, the agreed upon treatment is completed or is ongoing, we try to remove as many barriers as we can. And then a new area that's really come into focus that we're struggling with, and a lot of community hospitals are struggling with, is survivorship and how we're going to really implement that. Because a lot of what we do, and most all of what we do, is not recovered financially. So it is a struggle on community hospitals to know the needs and then try to meet those needs with the limited resources that we have. But we've had a great lung program, and we got that funded from Komen, and we did really well. We have had really good results. We showed that patients really did better with navigation. And so then we started looking at other tumor types and how we can make an impact. And we just happened to ask our pulmonologist, who is an interventional pulmonologist that's very well respected and very cutting edge, how come we see so many stage 4s? Why are we not seeing these early stages? And she said, Kim, it's because they come in and it's incidentally found in most cases. It's just a fluke that it got caught early. And so several years ago, we started looking at how we can try to identify anyone who comes in with anything that may need follow-up. Maybe not then, because it's small, but see if things change. And so we started an incidental nodule follow-up program where we review, and we worked with our emergency room doctors, because patients are in and out very quickly. You know, please tag this. We want to make sure that the patients are informed, their primary care is informed, so that a serial scan is, if it's needed in 6 months, that they are aware that it needs to be followed up. Or it could be that it's been there for a long time, and it's not changed, and the patient and the physician knew about it, but we didn't. So it's just that communication. So we started that, and we started identifying some cancers, and we still, to this day, we have some patients that are in serial follow-up. And then we also have started any inpatient or outpatients that come into our facilities, our radiologists tag those, and we're following up with these. And we've started a lung nodule follow-up clinic. We're hoping really to help change the tide from stage 1 and 2s to 3s and 4s. We really hope with what we're doing and making an impact in our community, and what the recommendations are going to be finalized with the low-dose CT screening, hopefully that will make a difference. I have a question for you on that nodule follow-up.
Yes.
With the pulmonologist and all the people on the team, when do you decide to take a CT scan? Where does the patient need to be? Are they coughing, symptomatic, for how long?
What we do is we don't make that decision. Of course, the radiologist report is going to say what they recommend, but the radiologists do not know the history of that patient. And if it's something small, if it's a mass, we're flagged, but we don't, it's handled urgent. It's not something that we can follow up a little bit later. It's just the bottom line is we want to make sure that the patient is informed that they need to follow up and check with their physician, because we don't know their history on a lot of these outpatient procedures. So that it's trying to educate the physicians on what we're doing as well, and that they need follow-up. And that's key. And it's been a learning curve.
I just have one more question for you, because one of the things we hear from patients all the time is that they had a persistent cough and they were symptomatic, and they're not getting x-rays and CT scans.
Yes.
So is that part of your program, to be more conscious about symptoms?
Yes, because if we have seen something and it's maybe small, but a patient says they want to go ahead and go to a pulmonologist versus letting their PCP manage it, we do try to work with them on that. It's hard in the community setting, because you do have to be very aware of the primary care role, and they want to be the quarterback.
Well, and I think one of the ways it becomes tricky, and I don't want to stick on early detection and screening for too long, but is that typically the referring physician is a primary care physician, right? Saying, or it's an incidental finding in the ER, right? So there's gaps in both of those places, because somebody's got to report back to the PCP, and then the primary care physician needs to know what to do with it or how to follow it, right? So by the time it gets up into the nodule clinic, where somebody qualified, like Dr. Garwood or others, if she finds something to push it on, you're going to, do you understand what I'm saying? Where the gaps are in the emergency room and with the PCP. So this is taking that and trying to flag it, to push it up into this nodule clinic, so that somebody qualified is looking at it and
Correct.
putting recommendations back to the primary care physician.
Now, when you're symptomatic, that changes. When you're non-symptomatic, you came in for a gallbladder, they see the lower scan, and then you're not symptomatic, and that could be the serial screening. But when you're symptomatic, that should push it to another level of more intensive workup. And then once, if they want the patients to go to the lung nodule clinic, we get them in there and get them seen by the interventional pulmonologist and take it from there. Another key factor that our nurse navigators play is we have weekly multidisciplinary conferences. And those, I say your patient is right in front of you when we're preparing those charts, because we want to make sure every scan that needs to be, we have, so that all the physicians can see it. All the pathology's there, all the molecular testing is there, all the results, as much as surgery, anything on the patients that we can have, so that all the physicians can get together and collaborate and make their recommendations. And then the presenting physicians will take it back and discuss with the patients the recommendations. And I think that is crucial to what we do. And some weeks we have 15 patients presented, sometimes more, sometimes less. And then a lot of times it's repeat patients that are presented as their different workup levels are progressing. And clinical trials, we are very tied in with Sarah Cannon Research Institute. We have our Tennessee oncology physicians really do have a lot of clinical trials with them nationwide. And we really try to connect what those needs are going forward, so that we know what the recommendations are, but yet it's still a personal, it's that informed decision making that the patients are making. And then we try to do anticipatory needs from that.
So the first thing you talked about is sort of a behind the scenes role of the nurse navigator, right? Getting everything that needs to be presented at tumor board, right?
Correct.
So, like she said, all your scans, all of your reports, all your past things, everything that these docs need in order to make that happen. The next thing I want to ask about is, so let's assume for a second that a patient comes in and they present at stage 4, and all of a sudden they're in a cancer center and their doc's throwing, okay, we're going to do this, 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 and this. Who helps to educate the patient not only on their disease? How do you do it? How do you help them walk through their new normal? What resources are available? Sorry, that was like 12 questions at one time. So let's...
What role does the nurse
navigator
play?
What role does the nurse navigator play for that patient that walks in at a later stage? How can you help them through this process, whether it's getting to CT, managing, scanning, whether it's infusion appointments or anyway.
Right. Yeah. And I'll back up just a little bit. The Commission on Cancer has now made it a standard, and it's a quality patient-centered standard where all facilities need to provide nurse navigation, but it starts with a community needs assessment. And we looked at what our hospitals, our physicians offer, what the community offers, and we try to fill in those gaps. And within our facility, we really saw the gaps early on around the surgery, the early diagnosis, and getting everyone into treatment as quickly as possible. So that's where we're focused. And partnering with Tennessee Oncology, they have a vast array of resources. They have a clinical psychologist, they have patient advocates and they do have nurses within Tennessee Oncology. So we really focus more on the front end, but then once they're starting treatment and they're with Tennessee Oncology, we work with Tennessee Oncology to see what we can help them with to augment what they already have in their offices. Their offices are really good at doing education, so we just reinforce because they have that. But we do have genetic counselors if we see that there's a link to that. We help, we know resources in the community if we have them come back to us with those needs.
So can you step back for a second and just explain how Tennessee Oncology works? I mean, I think Tennessee oncology is unique to, and what they represent is unique to states like Tennessee, Texas, obviously,
Right.
U.S. oncology. I don't think a lot of people are familiar with how that works.
Thank you. Thank you. And maybe the difference between like a major institution like UCSF up the road and a community hospital.
Okay.
How does that work with the oncologists and?
Right, and like we have Vanderbilt in our backyard, and it's an NCI dedicated facility, and you know, it's I think back and I go, it's kind of easier in a way. If I was a nurse, I put myself there because they all have one medical record. You have access to everything easy there. And in a community setting, we work with so many different independent physicians. So you think if you're being in community setting, you're moved from one physician to another, and you're told you have to get records. You know, we help with that. And as confusing as it is going through the process, that's why navigation is needed to help go through the process. So we're able to help that. And Tennessee Oncology is a group of a lot of physicians that make up most of Middle Tennessee. There's Vanderbilt that's independent from Tennessee Oncology, and then there's 2 independent physicians in the Nashville area. And then they also have some offices in Alabama and in Georgia. So it's a very large practice, so it does bring with it a lot of resources. So that's where we thought we would make the difference more on helping them get to Tennessee Oncology, or sometimes it's reversed. Sometimes a PCP will call Tennessee Oncology, and then we help with tumor conference, and then we reach out to the patients that end, because sometimes it is a stage 4 and they don't start with us from the workup part. We see them at the stage 4 diagnosis, and we work with them that way. And we have within our facilities palliative care resources that we're able to refer. And of course, palliative care does the wonderful job if hospice is needing. And we have all those community links that are needed. And sometimes you don't know what you don't know. And
so would you say, when you look at a major institution like UCSF and like Vanderbilt, everything is under one roof? The oncologist, the pathologist, the pulmonologist, the surgeons, everybody. And they actually work for the hospital. They're not in private practice. So I think what you're saying here is in your environment, your job is to keep continuity between all of those entities that are not under your roof.
Correct.
To the benefit of the patient.
Correct. Because as confusing it is for us to get records from here and there and track down scans, track down the pathology, and then getting the slides, getting the images and discs. You know, we're just doing the back end, and we're not going through the process like our patients go. And that's what I feel is fulfilling, that we're trying to help alleviate that. And we want to track down those images. We want to track down those slides so that patients are not having to go pick up things. We want to make it easy as possible so that patients can focus on healing and their co-survivors can help them with that.
So if it's not, so if it's not public knowledge necessarily that there's someone like you for these patients that are seen, how do they go about finding someone like you? Because I talk to patients all the time, and they're like, well, I have to go pick up my scans, and I have to bring them over here, and I have to, you know what I mean? How do they find you if somebody's not telling you that you are there?
Navigation itself is relatively new for other tumor types. It's been around breast cancer for a while, and it's beginning to branch out into other tumor types. And physicians are learning how we can help patients. And to be honest, I think by us doing the incidental nodule follow-up, I think that has created a lot of dialogue between primary care physicians that didn't know what we were here, and that opens the door. We now get calls from primary care physicians that now know what we do and what we can do even in later stages. So if you're a patient in a community hospital, I think the best thing to do is to just ask your oncologist, where's my navigator? Where's my access to a navigator? If there's not a navigator, then where are my resources that I can tap into? Because that's what the Commission on Cancer has seen as a gap, and that's why they want us to really do the community needs assessment. And if you don't have a true navigator, you should have those resources available.
So you touch on an interesting sort of part of the problem and the gaps here, and we were talking about it a little bit before the meeting when we were upstairs, and you know, this. We could talk till we're blue in the face about the payer situation and why people do and or don't do or support what they do and or don't support. But nurse navigation is one of those things that typically is not widely welcomed in the private hospital or community setting because it doesn't provide any income back to the hospital. It's a support service that is strictly there as a caregiving, you know, opportunity for the patient and or the paper getter to ensure that the patients, you know, are getting the best care possible. So it's a real big struggle, and we talk a lot about what patients can or can't do, and this is one of those areas that I think, you know, I've read paper after paper on navigation and the importance and the benefit back to the patient. But again, at the end of the day, as much as we hate to admit it, it comes down to dollar and cents for a lot of places. Clearly not, you know, a place like St. Thomas, and there's plenty of others who are starting to accept and kind of understand what this means to the patient. But I think it's something that if patients should start making noise about if you find that in your center there is not a navigator or someone to help
or be aware of it, because again, institutions, everybody under one roof. You have the multidisciplinary team. You have genetic testing. You know, this all happens from this one building. But in the community arena, there are many people involved. And you know, we have this program, and we developed it because of this issue to put together community centers of excellence across the United States. Because clinical trials happen, 50% of the clinical trials happen in 10 states. Everybody talks all the time about only 4% of patients participate in clinical trials. That's really because they can't get to them. So the other thing we ask our community centers of excellence, if they can't participate in clinical trials, that they will outsource the patient to a trial if that's the best possible solution for their next line of care. So what the job is here for a nurse navigator is to keep all those balls in the air and not letting any of them drop. Making sure the patient gets the same care they would get in a major institution, but it's going to happen a bit differently.
Well, and not to step on academia's toes, since you brought up the clinical trial space, but you're more likely with nurse navigation to get access to the best trial for you in the community setting than you are in the academic setting, where they are more likely, right, to say, well, these are the trials we have available, and you may or may not qualify for them, rather than referring you out to a clinical trial that may be in an academic center 30 miles down the road.
That's true, and the Commission on Cancer does now have as a standard requirement a certain threshold for participation in clinical trials to be an accredited Commission on Cancer facility. And so they see the need as well.
Yeah, I see. It's great. It's great. So what is the navigator's role in helping people through? Let's start with the diagnostic process and then move on into treatment. You know, insofar as helping to move through that place and educating patients on, you know, helping to make, especially treatment decisions, right? We find patients a lot of times coming to a crossroads on, well, I can go this way or I can go this way, and how do I decide?
I think sometimes just letting patients and their families talk about it. And we try to encourage reputable websites. You know, there's so many things on the web that maybe are not truly even a true clinical trial, or it's not the gold standard. We really do encourage just some journaling and thought process into making the best treatment decision for them and what side effects are possible for each treatment, and then making the best decision. It's sometimes hard when you're given choices. Sometimes you're not given choices. They're saying, this is what you need right at this point. And then, you know, sometimes they just have to think about that, and if they really question it, then sometimes there's the needs for second opinions.
That's what I was just going to say. I mean, do you help patients come up with questions to ask their doctors when they're concerned?
We do. We have, we asked that you start making a list of what questions to ask. And that, physicians are only in the room for a small amount of time anyway. And if you just say, I have 5 questions I need to ask, please sit here and let's talk about these 5 questions. You already have them there, and we try to help them organize questions so that, and if we can then follow up with those answers and talk through them. We try to help keep it in perspective and pinpoint exactly how to help them make the right decision.
So if you guys can't reach Michelle or my mom or myself, to try to reach your nurse navigator, your doctors to help you.
And truly reach out to your hospitals, because the more that you all proactively say, we need someone to talk to, we need a voice, we need someone to coordinate our care, that makes change.
Yeah, if you all start asking, where's my nurse navigator?
Exactly.
They're finally going to say, maybe we need a nurse navigator.
Walk in the door and say, I want my navigator.
Right.
Right. And we have within our navigation team, we have nurses, and then we have social workers, and then patient navigators. And our patient navigator can be either an LPN or specially trained that can help with a lot of logistical issues as well as appointment scheduling. But we leave our registered nurse level at truly a different level with education, with side effects and anticipatory guidance, what might come next. And then we have our licensed clinical social worker that can help in the other areas of social work. So we try to have a good team.
Yeah, so before we jump into kind of what the roles of some of those other team members are, I think you made a good point about walking into your hospital and asking where your navigator is, and nothing makes me, and I'm sure every single person sitting in this room and watching online, more crazy than, and I hate to always use the breast cancer patient as the example, but the breast cancer patient having all of these things sort of just spewing out of the mouths of everyone in the office as soon as they walk in, right? And the lung cancer patients having to fight for it. There are things more infuriating, but that's right there on top of the list. And I think, I know we're going to recommend that you guys speak up, and like Kim said, but do you think that there really would be benefit to that? Because they need to know that they're going to have impact before they go in stomping their feet and pounding their fists. Is it going to make a difference, right?
I think if enough people do that, it will make a difference. I think of Capitol Hill and Lobby Day, the more survivors that are there and presence, it does send a message. It really does.
But starting in your own oncologist
and you
office.
Start local, and start with your oncologist, start with your local hospital. And if they do not have somebody designated as a navigator, then who can I work with? Who can get me the resources and help answer my questions? And they may be called different titles. Within Tennessee Oncology, we work very closely. They have patient advocates, and they help with financial needs. We have within our hospitals financial assistance. So we plug you into whichever way you need help with. Is it the hospital bill, or is it the oncology bill and the medications? We try to help link that.
So since we went there, so those are the patient advocates, you said, that help with that. So is there also assistance through the patient advocate, or would it be through the nurse navigator, the patient coordinator, help with access to drugs? A lot of times the patients have a hard time accessing the drugs themselves.
Right. We help with that. Our social worker really is in tune to if they are needing drugs and they're not part of Tennessee Oncology, then we really proactively work with them on getting access through the drug pharmaceutical companies for patient advocacy access, patient assistance. But Tennessee Oncology does have that patient advocate that does it for their patients. Now, I'm going to be honest here. What happens is we have an infusion center within our hospital that the first part of the year, a lot of times the patients come to our nonprofit hospital to get their deductible met, and then they go back and get their infusions. We help get them to their deductible and work out a payment plan.
That's great.
So that's the thing. I love working for a nonprofit. We take all patients and work with them if it's $5 a month that they pay back. But we make sure that they get the drugs. So if it's something that we're working on in a hospital level, then we try to actively get those drugs paid for. And then if it's within Tennessee Oncology, then they do that. And so a lot of hospitals, most all infusions, it seems like, unless it's a physician employed by a hospital, it happens in their office. A lot of times, if it's a physician to own, they may have an outpatient infusion that's joint for infusions for, you know, MS or for bones or some, you know, multi-infusion center.
So I know that the financial aspect of this is huge for a lot of cancer patients, and I know there's some people in the room who can talk to using some outside resources to help to get access and financial assistance when paying for the drugs when their insurance companies won't pay for them. And we're grateful that some of these groups are out there. Do most hospitals, and I know you can speak for Tennessee and Texas Oncology and the way this all works, have some sort of financial assistance programs to help patients with these things, and or do they resource them out to some of the groups that we might be sending them out to? Do you know? Like you, St. Thomas, is an example. You guys have financial assistance programs. I know you said if we're nonprofit and if it's $5 a month, but let's assume for a second that we had a lot of patients in here talking about Tarceva and being on Tarceva. It's an expensive drug, right? That a lot of times insurance doesn't cover, at least not enough of it. That's not something that you guys can necessarily help with. So how do you help patients when they're trying to get financial assistance for their drugs? Is there a certain is it the social worker? Is it the?
Usually it goes to our social worker. Now we have her, and I think it's the ACCC. They have a booklet that is produced every year that has a summary of each drug company and how to access their financial information. And we have that, everybody has it downloaded on their desktop so that we can, if we get those calls and if we know of patients that need it, we know how to start that process going. It's just knowing that there should be someone wherever you're getting care that should be able to help you. And you shouldn't have to just worry about it and not ask. And I think that's sometimes an issue that I hear a lot is they're afraid to bring up financials because they're afraid they may not get the care that they know is recommended. And it's just, I think it's a new day. I think people are really thinking about finances a little different and the cost of things. So physicians are beginning to be more in tune of cost. I really have seen a tide change on that.
This is the difference of a facility having a patient navigator like this beautiful lady here and not having one, because she's your steward to, you know, connect you to all of those layers of stuff. It's you know, it's an overwhelming diagnosis as it is. And then once you get on, everybody talks about the new journey. Then once you get on this new journey, it's like, oh my gosh, you know, now I'm gonna go down here and I'm gonna go do this. So, you know, someone like this is really, really important. And we as a foundation rally for this to happen everywhere for you.
Sure. I don't mean to smile when you grabbed your head like that. I thought you were going to use a bad word and we were going to have to bleep you out.
No, I was just, I'm thinking about it. You know, it's just so, the whole thing is overwhelming. The diagnosis is overwhelming enough without having to now, you know, go back home and start, you know, penciling out all of these things and being on your own, you know, so.
We really want to make it as easy as possible for the patients and the families. That's the goal, so that they can, trying to remove those barriers, so that they can focus on healing And, you know, I've always recommended, please appoint someone to help with finances. You don't worry about that. Appoint a family member or a trusted friend so that they can get the bills. One thing that I always did when I was doing floor nursing 30 years ago is I would always say Sunday afternoon was the worst in Nashville, Tennessee, for visitors coming after church. And I would say, tell me a food you would never ask for. What's one food you hate? And I would write it down. You know, back then everything was paper. We didn't have all computers. And, you know, it'd be prunes. It would be, you know, orange popsicles. I would never ask for that. I'd write that down. And that would be their code to me that they were tired and they needed me to come in and shoo everybody out. If they said that word, I knew to go into mama bear mode and try to clear out the room and let everybody rest or go home or whatever needs to happen. And I think it's good to have as your support person someone that's going to be protective of you and your energy level and have a code so that if you do start feeling really tired, if people keep calling, you know, you really have that code so that someone can intervene. Because it's hard to sometimes kick people out because we want to be, you know, try to be as optimistic as we can.
I love that code idea for so many reasons.
Although prunes is really high on the list for somebody in chemo.
Well, but some people don't. Well, this was a surgery floor, and well, a lot of people like the prune juice too after surgery. So, but you know, something you would never ask for, and it's something either you were, you know, for some reason, I would always ask for something to be a code. It could not be. It might not be a food. It could be something else, but a code word that would just clear the room.
Yeah. I actually love that. I don't want to try to think about my word right now because it'll distract me from what I'm doing. But I will have a word.
We really want the goal to be the agreed upon treatment is completed or ongoing.
Yeah.
And you know, connecting you with palliative care and then hospice if need hospice.
So I'm curious if anyone in the room has had a nurse navigator, whether you knew she was a navigator or what she was doing or not, but a nurse navigator, a patient coordinator, a social worker, or any of these things that we're talking about today as part of your care team. And if you have, what was your experience with them?
I don't think they...
Nobody? Chris, you did?
Did you have one?
Oh, you know,
other than us.
I was sent to a social worker fairly early on at Palo Alto Medical Foundation. And it seemed like her function was to be kind of a cheerleader. And she gave me the forms I needed for end-of-life decisions.
Oh, nice.
This was early on. Aww. This was like in my second or third month. And I still have those forms, and they're still sitting in that pile of papers that I ignore.
Yeah.
I keep thinking, I guess I should look at them. And maybe I'm ready now, but I certainly wasn't then. And I haven't seen her since. I don't know that I was supposed to see her again. I asked her for support groups, and she, I believe she did tell me about the support group, lung cancer support group that meets once a month at Stanford, and she told me about some other just general cancer support groups. She never mentioned Bonnie Addario. I mean, here we have this amazing, fantastic, resource. I mean, and she never mentioned it. Pissed me off, actually. Do you have to bleep that?
No, I don't have to bleep that word.
Yeah, I had an experience with PAMF as well, and it was not a pleasant one after my surgery. I got a phone call welcoming me to the club. And I said, "What club?" She said, "The Cancer Club." And then she had me come in, and when she found out there was a family history, she sat there delving all into the family history and had me in tears. And then I had to go see another doctor after her who told me I wasn't handling things well because I was so upset for meeting this lady. It was not good, and I never got back in touch with her.
So this was you. Sorry. Had you already discussed a cancer diagnosis for somebody, or that was how
I
you
had surgery. And they had this lady, a social worker, call me. And I didn't think it was handled. I think it's a wonderful idea. I like what I'm hearing from you, but the way this particular thing was handled was not good.
So I have a question. What would you guys have liked to have happened once you were told you were diagnosed with cancer? You don't have to say that you would have liked to have been given access to us. You don't have to say that if you don't want to. I'm just teasing. No, I'm being, in all seriousness, what would you have liked to have happened? You've been diagnosed with cancer. What would the very next thing you would have liked to hear be?
Yeah, I would say, if I could, have the hope. Would you like to talk to somebody who's in the same position, maybe a little further out? Because I know, for me, having come here very soon after being diagnosed and hearing how long Bonnie had survived her massive trauma of having the lung cancer, and then hearing other people in that it wasn't an immediate death sentence. Forget, I wouldn't even had enough time to fill out the forms that Chris was given, but having that opportunity would have definitely helped me during the devastation stage.
Good point. Really good point. Anybody else?
When my husband was diagnosed, the doctor told me that it was cancer. My husband wasn't with me at the time. And I asked him, what do I need to do? What do I need to do next? Because I knew I had to keep it together, and that I was going to be getting important information. And he said, do you have children? And I said, no. And then he said, I don't know. And that was, nobody gave me, I thought that I was going to have a social worker or a nurse contact me to tell me how to manage the rest of our lives with cancer, and that never happened. Even going to MD Anderson and going to the top places, never once did anybody, any social worker, occasionally when he was discharged from the hospital, a social worker would come by and ask us how many stairs there were in the house. Because if there was a tripping hazard at home, they were assessing that, and that was the only thing that was ever asked, and it was a 3-minute thing, and it was at multiple institutions like that. And I think part of the problem was that I was there being an advocate for him, and it's kind of funny because after he passed and I started my business trying to help patients, cancer patients, I started going to doctors' clinics and places like that to find clients in business. And I found out that sometimes there are concierge. That's what they call it. Sometimes is a concierge and all this stuff. My husband's own clinic, I didn't know that there was someone there that was supposed to be helping with the rest of your life besides the clinical things. So the communication gap is definitely there. And sometimes if you have a family member who's advocating for you, those are the ones who slip through the cracks. They're like, well, you had everything under control. Well, I did, but I was lucky, and I was in a position where I was only working part-time, and my husband's company was really great, and they let him continue to work full-time. If we hadn't been in that position, I wouldn't have been able to go to every appointment. I wouldn't have been able to go wait in line at medical records to get his records and make sure that every place we went to, his records went with him and things like that. And there's this funny thing that happens. If you take care of yourself, then they only help the people that have no one helping them, but that doesn't mean the rest of us don't need help.
This is a great question that you asked, Danielle, because I know from my own experience, the day I was told you have lung cancer, they were making an appointment for me with a surgeon to do exploratory surgery because the biopsy I had failed. So I just got in my car, and it just so happened I was having dinner that night with 2 girlfriends, and my appointment was late in the day, and I'm just driving down El Camino, just being told, you have lung cancer, and they didn't even tell me what stage or anything, and it wouldn't have meant anything to me anyway, because they weren't going to explain it. And I went and met my girlfriends, and we ordered Cosmos, and just casually I said, you know, I have lung cancer. And they, you know, they're spitting out their drinks. And this is huge because the patient voice is missing from this whole process, from the beginning to treatment to everything. And I am a big believer that we are part of the solution, a big part of the solution, because who knows better? And this is a great conversation we're having. From diagnosis, it's not working properly, right?
And that was kind of the point I was trying to get at, because I can't tell you how many people I talked to that were actually told over the phone. Somebody called them, oh, P.S., I have your biopsy results and you have lung cancer.
Yeah.
Who does that over the phone? Go ahead. We'll get, you're next, Jim.
What?
I would love to have gotten a list of the top 10 things I could do to reduce stress, because the stress was literally off the charts. And, you know, things like just go to these reputable websites to learn more, or go to a support group, or exercise more, or, you know, just, that was the most immediate thing, was how do I deal with this? So, yeah, and the fact that there are resources that exist. I mean, this is the first I've heard of a nurse navigator. I don't know if it's just not a California thing or what.
It's not a huge, it's starting to happen, but very slowly.
Yeah.
But we want to carry your voice. So we want to know what would have made your experience a bit easier. You know, what should have happened that very first day when you were diagnosed to make it easier?
Yeah.
Well, thankfully, my doctor did tell me this is not necessarily a death sentence. This could just be a chronic condition that will be managed with medication for the rest of your life. So he gave me hope. Then that is really, really important.
That's great. Evie?
Oh, wait, sorry. I'm trying to take order here. So it's Jim, Betty, then Evie. Sorry. Go ahead, Jim.
Basically being accused of being a homer, my admonition to the audience here is that the science is moving so fast and the technology is moving so fast that, you know, one of the first things that if you're diagnosed, your physicians should say to you, well, we need to test you for, you know, for your mutations. There's 170 mutations. And Bonnie and Danielle know the people at Foundation Medicine who basically pioneered in this thing. And you may run the danger if you don't have a really, you know, frontline physician. They may not say that. It's critical to finding out if you can take Tarceva or some other drug. And Bonnie and Danielle are on top of that. And then, you know, if there's clinical trials, Danielle can probably direct you someplace where you can probably find more information. But I'd just be scared if I was going to XYZ hospital that someone might not say, well, you know, we'll do some radiation, we'll do some, you know, cisplatin, carboplatin, blah, 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 before you have your mutations tested. And that's what's going on. So anyway, it's just hospital to hospital, it's scary. What might happen if the person who you're talking to doesn't really, you know, just grab on top of the latest things that are happening. And the science is moving so fast, it's just scary, and that's to the benefit of everybody here.
Yeah.
Betty?
Who's next?
Hi. You know, I hated my messenger, and they could have done it any way possible, but what I really wanted them to tell me was it was a terrible mistake. So it took a while. They offered a lot of things up front to me, but I didn't feel that I was ready to listen to them. And so I think what I could have used most, I had both a case manager and a social worker, and they were both wonderful people, but it's taken me a while to learn that I really have to ask them for help, and then they'll help me. Mm-hmm. And what I think I could have gotten more from them sooner if they said, do you have questions for me? And tried to get me to ask questions or respond in that way, because this week I've determined Monday I'm going to do this, Tuesday I'm going to do this, and set aside my own goals. And when I ask these people, and when I come here and ask a question, there's this wealth of information to be had, but you have to ask. You have to pick up the phone. You have to email someone. There are tremendous support groups available, but only if you reach out. And so somehow getting people to know to reach out is a challenge, because you just want to kind of curl up and die when you first get a diagnosis like this. You don't feel like reaching out to anybody. So I don't know how that would, almost a facilitator for the facilitator, that would be a challenge.
So Betty, would it have been helpful upon diagnosis if somebody had merely handed you, a sheet of paper with resources on it? This is who you can reach out to for this, or this is who you can reach out to for that. I mean, I'm really curious about this because, and this is all circling back to a question I have for Kim about how we can do a better job. We, as the foundation, can do a better job in helping to facilitate this disconnect, especially upon diagnosis.
I can thank Neil. He's one of the first people I actually talked to that also had lung cancer, and I came here just searching around, and I was lucky enough to speak to Michelle and talk with people, because I just didn't understand anything that was going on at all. And just the cumulative mass of getting to talk to somebody and having my stuff in front of not a specific doctor who wasn't sure what they were going to do for treatment yet, it was very helpful. So I think what would have been most helpful for me would have been just pushing that ball to go down the hill just a little bit more. One more, there were a couple people that talked about getting the phone call from someone, but maybe while they were still in the office, getting one action they could do when they got home. So just one little thing to set the ball in motion for them. That might have helped.
Would it have been helpful if after you got home and or the next day someone had called you to see how you were doing? Would that have been helpful?
No. Maybe. I don't know.
No.
I couldn't say for sure.
Okay.
No.
Okay.
Evie?
Yeah, Evie's next.
Thank you. We don't live in utopian world, so I know that this isn't going to happen it's not going to happen, period. I mean, ideally, if the Bringing Hope Home patient handbook, lung cancer handbook, could be in every office, and before you walked out the door, they handed you, here is the handbook. Okay. That would be great, but I know that's not going to happen, and to the extent that you can get people who are their feet are on the ground, in the room with the patient, to say, this is what you can do. This is a resource. I find it curious that you go and have a root canal, you go and have cataract surgery, you have your tonsils out, they send you home with a piece of paper. When Neil had his cataract surgery, I went home with 3 pieces of paper saying, okay, in the first hour, do X. Put the drops in every X, blah, blah, blah. Well, why aren't you given a piece of paper with a lung cancer protocol? This is what you can expect to do. Okay, and I know that some people learn very differently. Some people read, some people have to hear it, some people have to whatever, do it visually, whatever. But at least if there was, here is something, and it has the list of the resources, this is the medical, this is the dietary, this is the what, whatever it is. But I mean, it seems to me if you're going to have a root canal or you're going to have cataract surgery and they send you home with a protocol, they ought to send you home with something when you have cancer.
Mm-hmm. Yeah, you're right.
So I couldn't agree with you more, and this is what I want to get back to, Evie, exactly what you just said and kind of talk to Kim about, because comparatively, if you're a breast cancer patient, more often than not, you are sent home with an entire package full of information and resources about what your diagnosis means. So I agree with you that it needs to happen, and I am hopeful that at some point in the very near future it will.
Yeah.
Yeah.
Can I add one other thing I'd like to say? or should I stop?
No, you can finish. And
Okay.
then I'll go.
I think that when you get a diagnosis of cancer or anything, you're entering, you're a student, you're a freshman, and you're in Cancer 101. And it seems to me that there ought to be an education process about, and you can call it Cancer 101. Or whatever. So it goes along with the whole thing about the education and establishing something that you can hand to a patient and a caregiver.
Yeah, that's great. We'll take the online question, and then Hope will come to you. There's not really questions, but there's comments about what they would like. A majority of them are resources provided to them, support groups, specifically one-on-one introductions to alike patients, so maybe the same age group, same sex, same type of diagnosis. But what was interesting is the conversation earlier had started about the misdiagnosis. Had the patient, one of the survivors in Florida, not looked at her reports or requested her reports before she left the ER and just happened to look at them a few months later, had she would not noticed something going on with her nodules. But that patient, after getting a second referral, which this warms my heart, as soon as she met the nurse navigator, she handed her our book. It's not a surprise because this hospital is spectacular. But she didn't have the heart to tell her she had already had one, so she still took it. But if we could, after traveling all over the country, we will still sometimes see those handbooks on people's desks, whether they're nurse navigators or they're physicians. I think, and I go back when Mom was diagnosed, her oncologist didn't know what it was like to go through a treatment until he was diagnosed with lung cancer. And so I think it's the physician asking these questions to their patients as well, so they can relay that back to the newly diagnosed patients. But it's super important.
And to your point, my oncologist was diagnosed with stage 4 lung cancer. He had a seizure at home one night after work, and he called me and said, and he was an amazing doctor. He was known. I mean, you just knew when it was your appointment day. Bring books, bring homework, bring knitting, because you're not getting in there on time. Because he gave every patient all of those things we're talking about. Hard to find doctors like that. He called me, and even on top of all of that, he said, Bonnie, I have to apologize to you. He said, I just didn't know. I just didn't know. Didn't know. I know now. I ended up his caretaker.
Well, and I think one of the things that's important is, short of your own doctors being diagnosed with cancer, what they learn when they come here and the feedback that we've gotten from the physicians and the speakers in listening to you all, because they're listening, they say has been like life-altering insofar as how they're re-entering their practices and their sort of views on how they're doing things. And albeit, for some, it's maybe a short-term change because people at the end of the day are who they are, right? But you guys are having impact that way. Hope.
Yeah, I just had one quick comment on that. So sometimes I volunteer my time at oncology clinics just to have time to talk with patients about the things that I wish someone had told me when my husband was diagnosed. And what we have discovered is a good thing is on their first chemo day or their second chemo day is when I meet with them, because you've got the shock, the diagnosis, like there's just only so much information you can absorb in those first days because cancer and all the technical information is too much. So, and not everybody starts off with chemo right away, but like that's sort of like the line where, oh, the shock and I'm in process, and you can kind of absorb this new information because it's like she was saying, like even if you have a great social worker or nurse navigator who approaches you the first day, there's just too much to accept. So like a little ways in, but not too far in, wherever and it may be a little different for you, but that's really where the approach, Evie's right, sending everybody home with a piece of paper seems like a minimum amount of information, but then the real like help can come when you're there's just that shock wave where you can absorb it a little bit later.
I agree and disagree because, what people do when they go home is they get on the internet And there's information on the internet about lung cancer from 30 years ago, and that is just not the same thing that's happening today. There's so many really positive things happening right now. So that's the last thing you want people doing, is surfing the internet and reading stuff that scares the hell out of them. Right, and give them this, and then say, read it when you feel like it. And this is chapter by chapter. It's upon diagnosis, you know, here's what you need to know, and it goes, you know, you could take a year to read the whole thing. But you need to leave that office with something. You just need to leave with something, not you have cancer, and your next appointment is, you know, or I'll call you and let you know when chemo's starting. It's like, well, what's chemo? What is that? You know, you need more. You just need more.
So many of the hospitals have patient libraries. If we could at least get one copy of the handbook in every, I know that's a chore because there's so many hospitals in this country, but I know I did that for a while with longevity before I found you people and got involved here. But it's a lot of patients do go to the hospital patient library, and if every doctor can't have it, at least if a hospital has a copy of it.
Yeah.
No, and I think pretty much a lot of hospitals that we, you know, visit, you know, throughout the year, we give them a handbook for their library. The problem is who's going to replace that book when a patient takes the book, because they're like, well, I'm going to take this book, and you know, because there are those patients that do that. But it's somebody constantly reminding them, you know, check and make sure that this book is available. I do want to say something that a survivor has to say about everybody in this room. She says, this group is unlike any other. Even the patients are proactive, intelligent, helpful, and optimistic. The local support group they offered to me when I was diagnosed were 2 other people, and all they did was cry and talk statistics. She said she never went back. And this is somebody on the East Coast, so it's 10 o'clock at night, and she logs in every month.
And you know, I never would have gone to a support group, ever. You couldn't have drugged me there, because I had this image of people sitting around and it being a just big, giant pity party. You know, and that's not what we're about. That's not to say that we don't have warm arms and we're not full of hugs, because we are. But our goal, we believe informed and educated patients live a heck of a lot longer than ones that are not. And you know, you hear the story all the time. Give them a fish, they eat for a day, but teach them how to fish, and they eat forever. And that's our mantra. You know, we want you to know everything we know.
Yeah. And not only advocate for yourselves, but for one another. I mean, because every time you're going in there and making noise, you're not just making noise for yourself, you're making noise for every patient that walks into that door to that doctor after you.
You know, if I could add to that, I would ask Kim, how often do you get patients at the community hospital who've gone through the early stages of devastating news, and so perhaps it's gone 3 or 4 months and they're starting to understand it a little better, but then they're going to you and they're challenging you on things, or they're really asking you about procedures, or they're advocating, as Danielle has just mentioned, in that way there. Do you hear from patients? You know, some of us here, I know, do it and make ourselves look terrible for doing it, but we don't care. But, you know, does it happen there? Is it encouraged? What do you do?
What we do is we have a large volume of cancer patients in our system. We have over 4,000 diagnosed each year. So with our tiny staff, we cannot constantly follow up on patients routinely like we want to. So we try to make the initial contact and assess the needs, and then we will triage from that. And we always like to follow up, but sometimes we try to reach patients when they're away, but a lot of times we try to see them like at radiation therapy or at a doctor's appointment, but we don't, sometimes we do not follow up. But we really do try to triage those who may need transportation, who do have those financial needs. We try to connect them to those resources and follow up and make sure that they've happened. But we cannot truly follow up on everybody unless they said they needed something. But we always like to give them our contact information so that they can contact us.
And I think it's important to note what you just said. And St. Thomas has taken our education materials, and Kim and I were just talking about it earlier because, my mom held up the new book, which we were going to talk about at the end of the meeting. But we talked about the new book and passing it out, and some of our other partners in the Center of Excellence program are good with that, passing them out to patients, getting back to us saying, hey, Danielle, Michelle, we're out. Can you ship me another 100 or whatever? And we, of course, will do it in a minute. And what I think a lot of hospitals and cancer centers and doctors and nurses don't realize is how we can alleviate some of that burden, right? So we talked a little bit about, resources within the hospital that are there to help the patient, but we didn't really talk about outside resources such as our foundation, and there's some others out there that provide different services that would be really meaningful clearly to this group. I mean, obviously they know us, right? But we talk all the time about as many lives that we touch every day, patients and caregivers. There's hundreds of thousands of people and millions really around the world who don't know who we are, and I kind of do this not to be a narcissist, but that don't have the benefit of finding us, because people that do have that, I'm proud of what we're able to offer patients. I think it's comprehensive and it's easy to understand, and the services that we provide are filling this gap, right? And so the more people can really, this sounds like a commercial for our foundation, doesn't it? Good night.
Well,
the
we
more,
should have a commercial.
But the more people, the more resources patients have, and I think we hear that going around the room, the better. And the more we can all help one another as a whole, not just in the cancer community as a whole, but in the lung cancer community, where there's such a need and there's so many gaps across the board, the better for everyone involved.
And tagging on to that, you've gone through the diagnosis of cancer, whether you've had surgery and adding chemo or adding radiation. Then within the communities, there's sometimes several organizations you can tap into. There's American Cancer Society with the Hope Lodge that we have. Some communities may or may not have that. They do tend to have Road to Recovery in a lot of areas. We have a local Gilda's Club. There's also, it's called Cancer Support Community in other areas. There's so many different organizations that you've got to process and see where you can be plugged into. There's the Lung Cancer Alliance, and they're partnering with our local Gildas to have a true dedicated support group. So it's hard for physicians, I think, sometimes to remember everything they have to remember and keep updated. Sometimes they don't know the latest in the community as well. So really just asking who knows the latest resources? Who can I ask for local and national that I can tap into?
Well, and I think that's important, and I know you have something you want to say, but we've partnered with Gildas and the cancer support community and some of the other, the ACS and Road to Recovery and some of the programs that and they're all listed in our place. So that's why it's important for someone on this team to be looking out for who's sort of this one umbrella place who can give all of this information, right? Rather than us trying to figure out who we need to give what to. Yeah.
I think we go back to what Neil and Evie, and primarily Evie said. It's when you leave your appointment after your first diagnosis to go home carrying something that you can peruse at will and, dive into it when you feel like it. Give it to your spouse or your kids and say, here, you read it and give me the highlights. It can be a lot of things, but to go home empty-handed after you have been told you have cancer or really any life-threatening disease is criminal. I just think that's the ultimate persecution you can actually put on someone, to go home empty-handed, having no knowledge. Knowledge is power, and knowledge can be comforting, if you have the right information.
Correct.
Online?
There's a survivor on the East Coast, another one on the East Coast. A lot of
people logging in late at night. She was diagnosed in 2007 with stage 4, and she says at that time she was extremely grateful that she was genetically tested, but which is the reason why she herself continues to be an advocate and a voice of lung cancer in her area. And it goes back on the fact that we need every single person in this room continuing to talk. Sure, there's days that we don't want to talk about lung cancer. I call it on vacation days. But we need the continuance of advocates continuing to talk about lung cancer, because survivors are surviving a lot longer now than when my mom was diagnosed, and it's a huge issue.
And something you need to know, everything is measured by 5-year survival rate, and that's only gone up 2%. But what has gone up immeasurably is between 1 and 5. That's where you're seeing the big, clock ticking, which is really very encouraging. So,
well, I think it's important to point out why it's encouraging and why it points back to our goal of chronically managed disease, is because while we're chronically managing between 1 and 5, there are so many things coming down the pike, so many new things, so many new targets to be discovered that we want our own piece of the pie. Do we not?
Right.
That's right. And so it's all about what is happening in those 5 years while we're managing with what we have today. So it's
I was going to
very
introduce you to
important
Stephen Young. Stephen, here.
Hello, Stephen.
Our second foundation, Alchemy, and we're driving our own research and clinical trials, and he is the COO.
He's here somewhere.
He's here in the building somewhere.
Michelle's going to go find him. So
I do have a question
Yep.
for everyone. Has anyone that's actively going through treatment right now received a psychosocial distress questionnaire or been asked their distress level? Because that is a new requirement that's coming from the Commission on Cancer, and I think all hospitals are struggling how to. It's like it's for the betterment of patient care, and we're trying to enact and make better patient care with limited resources. And I was just wondering if anyone has filled out a distress or been asked distress questions. And what we're working on right now is going through our chaplains, and anytime an admission assessment is completed, we're asking, how peaceful are you? And we're hoping that will open a dialogue with it upon admission to discussing how at peace we are, and then they can dive down into maybe any distress, and it could be, I don't know how I'm going to get to my next treatment, or I'm having issues paying for my electric bill right now. So we're hoping that will help, as well as spirituality.
So that brings sort of another question. We're just sort of doing this live survey tonight online, but for those of you who haven't been asked quality of life or distressed surveys, how many of you, based on short conversations you've had with your doctors, have been prescribed sleeping pills or antidepressants or Ativan? Anybody? Most people. So it's a curious question to see.
No, but that's kind of like a replacement.
Well, that's what I'm saying. Instead of dealing with what is actually happening here we go. I can fix this, right? So.
Yeah.
I just have a little story today. Had my 2-month appointment after my radiation and chemotherapy ended in November, and so my oncologist told me, oh, by the way, I can't prescribe Ativan for you anymore. And I said, okay. And he said, because you finished your treatment now. And I said, okay, well, what is more stressful than having cancer? And he said, well, I don't know. You'll need to talk to your primary care physician. What is the difference between myself trying to cope with the stress of this debilitating or possibly debilitating disease and one small pill a day that helps me feel like I'm in control? So that's just what happened today.
Good question.
So I have a follow-up question. When you're released from your oncologist back to your primary care physician, has there been communication between the physicians on your care? That's a gap.
No.
They're all supposedly still on the same team.
Mm-hmm.
It's up to me to communicate.
I have a comment for that. I think every person diagnosed with lung cancer, all of you people online as well, need a pulmonologist in your life forever. And if you don't have one now, go out and get one, because what we just talked about is your surgeon is going to do whatever and say goodbye. Your oncologist, God bless, you know, you're saying goodbye. You need a pulmonologist because that's the next step, because your primary physician isn't empowered to take care of a lung cancer patient. They are if you have the flu or, you know, whatever, but get a pulmonologist and find one that is experienced in lung cancer. And then you have somebody there all the time that can help you. Get off my bandwagon now.
Go ahead, Lee.
You know, occasionally you mentioned the book. I gather it's a booklet that's probably post.
Don't show it yet. We'll just tell.
Oh.
Trouble.
Oh, okay. You just answered my question.
Trouble.
I was just wondering if I didn't know about this book, but since it's post diagnosis, you know, it'd be kind of interesting to know if it's available.
So, you're one of the new faces in the room, right? And we're so, like I said earlier, so happy to see you. And there's no chance in hell, pardon my language, that you're leaving here without a book tonight. So don't worry.
The book club. Yeah. And it's free.
Go ahead, Mary.
When I was diagnosed in 2010, I was at PAMF, and they did the genomic testing, I don't think the whole thing, but my oncologist said, okay, you know, you have cancer, but you have after the biopsy, you have the EGFR, and that's going to be your silver bullet. And so it was all such a surprise, and I didn't really know anything. So I just trusted the oncologist at the time, and it all pretty much turned out really good. And then, you know, after a year, I went and found a lung specialist. But what I'm trying to say is, like, you know, I knew nothing about, and I don't even know if you have enough time, because you want to start getting treatment within 2 weeks or a month at least. Mm-hmm. But I just feel lucky that at PAMP they did do that testing, and I knew I had the EGFR, and so it gave me confidence. So it wasn't quite, she goes, that's really going to help you at some point. Mm-hmm. And but she just said, this is what you have: carboplatin, Alimta, and Avastin. And that was kind of the standard of care at that time. I guess some people were giving Tarceva first. I had Tarceva afterwards, you know, a year after. No, not a year after, but I had radiation, and then nothing for 10 months, and then the Tarceva for 2 years. But my only point is like, I was so clueless. And now I feel like, you know, I really am proactive in my care. And I'm not afraid to ask questions. And but it all came probably from coming here. You know, you guys really teach well about getting second opinions and being your best advocate is yourself, because you know your body.
Mm-hmm. Well, and I think this is sort of one of the points tonight about the role of nurse navigation and the role that they can play, and why what Kim is doing with her team out in Nashville is so important, and why this conversation needed to happen, because it needs to happen more often, right? Where you are diagnosed and you know, hopefully, you know, you've gone through the proper diagnostic process, and your first line is treatment is going to be the best treatment for you. But what we also know, and what we've learned through you guys, because we do learn a lot through talking to you guys, is that it's really important not only to have a plan B, but a plan C, a plan D, and a plan E, right? And so someone talking to you up front about what are my plan B, C, and D options? What might those look like? Somebody letting you know up front that, you know, cancer ultimately, for most people, becomes, you know, resistant to the drugs that are holding it back. Nobody tells a cancer patient that when they first start treatment, right? That's important information because it gets your wheels spinning and empowers you to start thinking about, okay, what happens next? We're not going to talk about when that's going to happen or put definite numbers on when resistance may occur, but if and when it does, I sleep better at night, and that's a Natalie DeMarco quote, knowing that I've got, you know, my next plan in my back pocket. So,
yep.
If I could add to the gentleman you mentioned about the book. So I got the book after I was diagnosed and went through some really tough early stages, and I spent probably 3 months doing research. When I finally did get the handbook produced, I read through it and I said, oh my God, I would have saved the last 3 months from doing it. But one of the things that I have done since that time is when I get care at Stanford. So when I go for my appointments, I bring copies with me. And I will ask the people who are now in Clinic C, because they're there on Thursday or a Monday, they probably have lung cancer. So I will go up and first apologize for asking the question, but then when they say yes, I offer them a handbook. And in that way there, I may also tell them about the foundation, because like we know, even the people who live around here don't know about it, and they've been diagnosed, and they haven't heard from anybody whatsoever about that. And now we have a new second generation handbook, which can be easily updated, I've learned, so that it will be the most current information. And it really does help. And I've looked through it most recently because I have to have a new treatment, and I wanted to see what it said. And I found it very valuable to have that because it's been vetted, so you know it's coming from somebody who knows what they're talking about. Not me, but somebody really knows what they're talking about on that part there. And then one question I would have for you, Kim, now you said you're near Vanderbilt, so it's a NCI hospital and you have some other centers. Do you feel it incumbent upon you or the other nurse navigators at a certain point to graduate the people that you're dealing with to go to Vanderbilt or some other location that would have the clinical trials already, have a medical record set up so that all the information can be shared electronically within a location? Is that something that happens at your hospital?
Not typically, no.
I think that's actually a good question.
It is. But not typically.
But not typically, and I will tell you that I think St. Thomas probably sees more patients annually than Vanderbilt does, lung patients. But they do have an amazing program set up, so they don't. I don't want to say you don't need to, because there's not going to be that maybe that one-off patient that you're not going to refer out to a clinical trial or something like that, whether it's at Vanderbilt or someplace else. But it's an interesting question.
Mm-hmm. Well, clinical trials are very specific to the patient, and they're very different everywhere. And one institution doesn't offer every clinical trial available. So the ideal solution, and you can actually do this by navigating your own clinical trials. We actually have some software that allows you to do that. You type in all your specifics, your age, your gender, your diagnosis, what you've been on thus far, where you are in your treatment program, and the best clinical trials will pop up just for you and tell you where they're available. And that's how you enter into a discussion with your physician and say, well, what about this? And have an educated conversation about that. And the trial they have could be very similar to and equally as good. And again, educating yourself and empowering yourself to get the right treatment.
Kim, let me put you on the spot again. And that is, how long will it be until you replicate this type of setup here, the living room, which is now vetted, proved that it works very well, does a great job online. And maybe it doesn't have to be for lung cancer, because I understand you deal with patients all across the board. So you'd form it in the way that you want to, but when will it happen?
Oh. Well, we refer.
He's tough.
Yeah. That's the thing. One hospital, community hospital setting, cannot do everything, and that's where we have partnerships. You have your local partnerships, and then your national partnerships. And I don't see us setting up a living room there. However, it's really good to get. Our goal is to have every patient have your information and connect them.
And one of the things, Neil, and then Evie, I see you, that's important about what you just said is it's true. We aren't bound by the same regulations that certain hospitals are, or hospitals are in general, right? But what we can do in these cities and in these centers is something like this can be hosted in anybody's living room. Anybody who's got a computer, and they can plug it into a TV, right? I guess you wouldn't even really need a TV. And you can, anybody, anywhere, as a group, can sign into this meeting, do your own around the rooms first, and then somebody be moderating, just like Andrea is, to ask questions of the speakers. We can do that anywhere, and we're in the process of doing it in a couple of different places, and not just in this country, and connecting to this very meeting.
That's a good idea.
And we could actually have pictures of the patients in the other facility up there.
Right.
And you could talk to each other.
Video conferencing.
But just link right in with this. We've got the topics, we've got the speakers, we've got everything happening, right? Rather than trying to recreate the wheel in their own environment.
And that is going to be how these systems change for you. So you get what you need. That's going to be what it's going to take to make great change for lung cancer patients.
So go ahead, Evie.
If there are any doctors watching or nurses or whatever, I would encourage you to leverage the power of the waiting room. It doesn't matter if you're in a hospital, if you're in a doctor's office, it doesn't matter if you're in South Dakota or you're in Boston. People are sitting in the waiting room. Why am I watching CNN? Why aren't I watching an educational video that explains to me what cancer is? I mean, we all talk about cancer to people. Could you explain what exactly cancer? I'm not even talking about lung cancer. I'm just talking about what cancer is. And I have had this experience once, and it was in my eye doctor's office, and I know everything there is to know now about the cornea and the retina because I've been watching the video in the waiting room. So why can't it be an FAQ, and it could be in every doctor's office? And it ain't going to cost a lot of money either. And it could also have the list of resources that people could contact. Also, when you go for a job interview, you watch a video, learn about our company.
Yeah.
Right.
So it's the same thing.
Yeah, good point, Effie.
So that's actually a really good point, and you're making me think about new additions to programs, which
careful what you ask for.
Makes
We'll
me
put
crazy,
you in charge of it.
That is a really good idea.
But I'm thinking, because my sort of my final question to Kim before we went into some of the things about the handbook that I want to share with you guys and some events coming up was going to talk about these barriers and what I've heard several of you say tonight, like, why didn't somebody hand me that? Why didn't somebody say, I'm so sorry to tell you the biopsy came back positive and you've been diagnosed with blah, 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 lung cancer, right? Whatever the type is. And then hand me this book. How do I make that happen, right? And I don't know what it is. I don't know if it's a storage issue in doctors' offices and in hospitals, and they can't store the books to keep up with the patient population. I'm not really sure, and I guess that's my question.
And it's a struggle because our patients being told in the pulmonologist office after the interventional pulmonologist, is it being told in a thoracic surgeon's office? Is it being told the diagnosis in a oncologist office? Or in a primary care office. And that's a lot of moving parts in a community setting. Where do we have the resources? Definitely your oncologist and your thoracic surgeon and your interventional pulmonologist, but reaching the primary care providers, it is a challenge. because we can truly have them locally on a stash or a resource page. But
so let's assume for a second that this is Hospital X, and who's responsible for giving those educational pieces to the patient when they walk out the door? Is it the doc? Is it the nurse? Is it the front desk person who is making their next appointment? Who's doing that? Like who?
When they see a navigator, we give them the book.
Yeah.
And then we do have them in the different doctor's offices. But to make sure that it's assigned to somebody, we have not taken it that step.
Yeah.
And that's a good idea.
That's how you create a standard of care.
Where it's like a checklist.
That's a really good idea. To make sure that it's it could be the checkout girl.
Right?
Who's
she's making the next
appointment. The next appointment.
Yeah, right.
Whoever's checking out. We want you to leave with this in addition to your next appointment.
Yep.
Does anybody have any final questions before I move on to ALCF stuff?
I want to thank you all for truly letting me brainstorm with you all, because you all are the experts. You've walked through the process, and your sharing with us really helps me and any other medical professionals and nursing professionals learn to better the process for those going forward. And I always tell my patients, if it's good to hear what others are going through, because if you tell your friends that you've gone through cancer, you're the expert. So you're the one they call if they know someone who gets diagnosed. So it's really good that you keep on top of the newest treatments and the testing. Even though it may not impact you now, it may impact a friend or family member down the road, because you're the expert.
Let me say thank you for coming here and talking with us and giving us a lot of information we hadn't heard before. But also, so when will you come back and train the nurse navigators at the community hospitals and the research hospitals? So when can we book your flight?
I would love it. I love San Francisco, and thank you all for bringing me up here to enjoy the beautiful, beautiful city. Thank you. Thank you.
So on that note, I'm going to let you hold it up while I talk about it.
Oh, thank you, honey.
Version 2 is out, and I know she gave you a sneak peek earlier. So I want to talk a little bit about the new version, because it looks incredibly different than version 1. It is a bound book. It is fully updated as of
Cute patient on the front.
literally like December 10th. There's nothing new that happened prior to December 10th that isn't in this book. We did change the cover. It's way easier to manipulate. It's much, much lighter. And we're very, very, very proud to say it's also available now on Amazon. So we are on Amazon.com. Again, we say not to bring the narcissist out in me again, but for the people who aren't fortunate enough to find us, they may be able to at least find this resource on Amazon.com if that's a place that they're going to look for resources on navigating their disease. So we're insanely proud of this. One of the coolest things that can happen with this, because it's in digital print now, as new things happen, we can immediately make updates, and the very next print version that goes out has the current update in it. So we're really excited.
It's going to be second edition forever. It's going to ongoing second edition.
Yeah. Some of the things that are really interesting additions to the book are not only some of the new drugs that were approved, but there's a Hope on the Horizon section. So there's a huge section in here about immunotherapies, which we've talked a lot about specifically over the last 6 to 8 months, and some of the really cool things that are happening there, really taking sort of a deep dive into what is all this PD-1 and this PD-L1, and what does this mean, and what does this mean to me, and how does immunotherapy work? Ganeet Waileo, I don't know if Ganeet's here. No. Did she leave? Who
explains clinical trials.
Who works here. The clinical trial section, well, let me finish. Ganeet did a really good job at taking the immunotherapy stuff and dropping it down to sort of match the language level that we were able to get this book at. So it's a really cool section. The clinical trial section, and I know Neil was one of my early viewers of the prize poodles and guinea pigs article that was written by Dr. Ross Camage out of University of Colorado, Denver. He does a really great job of explaining what a clinical trial is, because I know a lot of you who have been with us for a while know and have heard us, talk about sort of the misinformation or misnomers out there about what a clinical trial is. But for those of you who are new, this is a really cool section of the book with some really fun pictures of poodles. There's even a pink one in there. He titled it, Who Are Clinical Trials For? Guinea Pigs, Test Pilots, or Prize Poodles. And it's really sort of a play on words for how you guys feel as patients entering clinical trials. But it's written really, really, really well. So that's another new section. So we're happy to give anybody who has an old copy a new copy, if you'd like one, so you can take a look at it. And anybody who hasn't received a copy yet, I think I saw Stephen Young just bring you one. We're happy to help you navigate it if you need help with that. Yes?
Online version questions.
Yeah.
Online.
Is there an app for this or anything?
So if you if you go to our website, if you just want to download a version, you can click on our website, and it's the current. The current new version is available on our website for free. Yeah. Our mobile app. I think we announced that last month. I wasn't going to say anything yet because they haven't finished uploading the new version to the mobile app. But stay tuned, and I will let you know when that happens. Did you want Stephen to say something? I know you called him in here before I move on to a couple of other
No, I just wanted
things.
to introduce Stephen. We started a second foundation in 2008, and this is because we decided what we were currently doing with our first foundation was never going to be enough to really change the statistics of lung cancer. So we started a second foundation, which has a tissue collection and blood collection and plasma collection from both major institutions internationally as well as locally, and it involves community hospitals. And do we have some clinical trials of our own right now?
Yeah, Stephen's going to need to grab a mic.
Yeah.
Excuse me. Yes, as Bonnie just said, Alchemy has 4 clinical studies underway, focusing on genetics, inherited genetics, but also acquired genetics. Early detection, we're working with diagnostic companies to look towards blood-based diagnostics. We're looking at the molecular genesis of the disease. We're working with Foundation Medicine, who you've all heard, many of you have heard of, at really doing a deep dive into the genetics behind this disease to not only identify targeted therapies available today, but also to work with the biopharmaceutical industry to develop targets for tomorrow as soon as possible. We're also about to launch an epidemiology study on a global basis, looking at, if you will, all the other factors that go into perhaps developing cancer, environmental exposure. I could literally go on for an hour, and I know I'll get yelled at. So the bottom line is Alchemy and the Addario Lung Cancer Foundation work together as a team to drive progress to patients today and tomorrow. And it is unique that we have our own tissue banks and our own data systems. And every study we take on has to have a demonstrable patient benefit. And to that end, Bonnie sits on the scientific board that approves or disapproves the studies that we take on, and Bonnie has veto power so that we cannot possibly be taken over by the old boys network of doing Me Too studies. That would not happen because we're very careful about the docs we're working with. But excuse me, exciting times. And we're also exploring immunotherapy. We're collaborating with various companies on immunotherapies, which is probably the most exciting thing that has come out of 2014.
Just because it kind of came up, I think we only have one tonight anyway. One small cell patient, in the room. I don't know that anybody else in here tonight has small cell, but. I think it's important to note that that's been a big part of discussion around the Alchemy Roundtable.
And yes, I just heard an update from Dr. Roy Herbst at Yale University. Well, I stepped out of the room, and anecdotally, they're seeing small cell patients respond to checkpoint inhibitors, the immunotherapies. And that, of course, brought up an immediate idea that he's seeing this anecdotally. What can we do as a formal study within Alchemy and partnership?
I think it's also important to note that Dr. Roy Herbst at Yale, who Stephen was just talking about, is quoted on the back of the new handbook.
Can I follow that real quick? Are you aware of anything out there for a small cell? But just exactly like you just mentioned.
This that's the first I've heard. Danielle and Bonnie are closer to it than I am, but this is the first I've heard small cell brought up in the context of immunotherapies, checkpoint.
Of checkpoint, yeah, that's the first I've heard of it too. Although I think to the bigger question is, are there trials available in small cell out there? And
not that I know of.
So the answer is yes, though.
There is.
Yes. There are.
Oh.
There are. And the Recalcitrant Cancer Act that was passed about a year ago for pancreatic cancer and lung cancer and all small orphan cancers, the NCI has committed X amount of money for small cell.
So
to work on just
to build on what
small
Bonnie
cell.
just said, the National Cancer Institute was basically encouraged to come up with a strategy on lung cancer, and they decided to focus on small cell. And so out of that came a strategy and a series of studies that are going to be coming out and proposals coming out from the National Cancer Institute. And both foundations, plan to be part and parcel of driving those studies forward. Small cell is a major, incredible unmet need, as we know.
And we'll get some information for you currently. Okay.
Can I ask a question? Right here.
Yeah, there you go. Sorry.
When your doctor says national guidelines don't, or the insurance company says we're not going to do this because national guidelines haven't approved it, is that the NCL?
NCCN. NCCN.
Is that what that is?
National
Yeah,
Comprehensive Cancer Network.
Yeah, and this is where your voices are really important too. And I want to answer that question. They're giving me this. So let me say a couple things. I'm going to answer it. You're not leaving tonight without me answering it, and I'll answer it to the group. I just got to do a couple things before this goes out. Okay. A couple of housekeeping things. First of all, I want to talk about next month's living room. We've got Dr. Diane Shume, who's a PhD and psychologist from UCSF, coming to talk to us about coming to terms with diagnosis, the emotional impact, and how to deal with that. She's very, very well known, and we're really, really proud and excited to have her coming next month. So that is February 17th, so everybody mark your calendars. As an FYI, the new living room calendar, or at least this PDF, is up on the website for everybody to see. A couple of events coming up. We've got our Irvine 5K January 24th. It's this Saturday, so if you know anybody in Irvine, or if you're online and you haven't signed up yet, please come out and see us there. March 1st, Tempe, Arizona. Gainesville, Florida. Karen, if you're online, is coming up on March 7th. And then, of course, Dallas, Texas on April 18th. February 26th as independent fundraiser in Tracy. All of these things, you guys can come back and ask us information. I'm getting this. I'm getting this. I'm getting this. AYA. Genomics Young. Yeah. February 26th. February, our February living room. I can tell this to people online. I need to say thank you, and then we'll come back to that. I need to give, 5-4, or I've got 9-8-7. Thank you very much to all of our generous supporters, Lily, Novartis, Celgene, BMS, and Merck. Thank you all for joining us here tonight. And I'm off, right? Yeah. So now I can go back. So, sorry, it's this weird thing we have to do for purposes of TV, because some of you do or do not know that Peninsula Television, which is local cable TV, replays this throughout the month over and over and over for anybody that wants to watch it. And we do get a lot of people that watch it, but it's a 2-hour time limit, so they make me say goodbye at 2 hours. We can continue this, and people online can still stay. So anytime I do that weird, awkward break, I hate it, and I wish there was a better way to do it, but short of them just cutting me off. Anyway, we've added some new meetings to our living room speaker series. It's part of our AYA series, which stands for Yeah, adolescent, young adult. You know, we work a lot with some of these young lung patients. February's meeting, and I don't have the correct calendar here, it's the 27th? Thursday, February 26th. 26th. So it's in addition to the meeting we have on the 17th. It's Barbara Gitlitz coming up from USC to talk about the genomics of young lung cancer study. And I think it's important to mention because what we're hoping to find from this study is not just impact on, you know, the study cases, which are patients under the age of 40, but how it will impact lung cancer as a whole, i.e. every single one of you in the room, what we might find by studying them that could then come back and benefit lung cancer patients diagnosed across the board. So you'll be seeing some emails come out about the AYA series as it comes up, and as to whether or not you want to come and see what's going on with that. We're excited about it. We're adding a couple of road trip remote living rooms to the calendar this year too, so you guys get to sign in and be part of the other end of it.
And if I can do it, you can do it. It's really easy.
Yeah. Well, no, and the neat thing is these young adults are actually the ones that are continuing to be the advocates for every single person in this room. So bringing the young adults to the meeting on February 26th is also part of what we're doing. So there will be a couple people from Jill's Legacy in attendance as well, along with some young lung cancer patients and Barbara and Stephen Young.
Well, and you know, one of the reasons we got involved in this study was a little girl. Her name was Jill Costello, and this was about four years ago. She was the coxswain for the Cal Berkeley crew team. She was diagnosed with lung cancer at age 20 and died before she was 21. And it was like, what? What? You know, this is crazy. So then a girlfriend of hers, Kelsey, worked for the district attorney in New York, and this was like a year and a half, 2 years after Jill died. She was still so passionate about it. She wanted to do something in memory of Jill. So she decided she was going to run across the United States from Boston to San Francisco. She did that. She ran across the United States, which was the equivalent of 2 marathons a day. So I called a friend, Amy Marcus, at the Wall Street Journal, and I said, Amy, are you interested in writing a story about a young girl running across the United States in memory of her best friend and about young lung cancer? She said, give me data, Bonnie, and I'll write the story. So I got on the phone and called a bunch of docs, and no data. It had never, ever, ever been looked into. So that led us into doing our own study on the genetics of young lung cancer. And we partnered with Foundation Medicine. They're doing all the deep gene sequencing. The tissue is coming from all over the world. And we're going to learn from this. We may have a new marker for you. Who knows? That's my personal goal. But the good thing, the really good thing that's coming out of this right now is that all of a sudden now the media is interested in lung cancer. And somebody said to me during Christmas, and we did a little thing on young lung cancer on social media, and they said, well, I can't participate in this if all you care about is young patients. And it's like, come on, have you ever been to our living room? You know, we care about everybody. So media is happening. It's happening. Lung cancer is a very stigmatized disease. I said to somebody in the room tonight, I think it was you, before the meeting, I said, do you know in 1985 lung cancer surpassed breast cancer as the biggest killer of women? And she said, I didn't know that. How many of you knew that? 1985. Okay, a couple hands up, not many. And consequently, the media is needed desperately. We need funding, we need research. It's the only way that people are starting to talk about lung cancer. So we're all going to benefit from looking at young lung cancer. People care about young people. I mean, you see the commercials on TV about the dogs. And, you know, what's the opera singer's name who's singing about the dogs? And I love dogs too. But it's young, and people care. And that's going to benefit all of us in the long term. So I hope you support us on that effort as well, because you know we care about each and every one of you equally as much. Smoking is the biggest cause of heart disease, vascular disease, all cancer.
I knew she wasn't done. That's why I just looked at her for a second. I was like...
But lung cancer got singled out as the only smoking disease. And I'm going to give a shout out to the American Cancer Society and the American Lung Association, who created the stigma in my mind, because they put all those horrible commercials on TV with people smoking in their stomas and all of this stuff. And all it really did, it didn't get people to stop smoking, but it got people to think of people with lung cancer as disposable. And we are not disposable. And we're going to change it. And we have to. It has to change, because the survival for lung cancer isn't going to change significantly until we do that and develop a real early detection program. So we're on it.
And my goal is to have 12 survivors.
What?
My goal is to have 12 survivors on the Titans field.
Perfect.
And
Perfect.
I was sharing with Bonnie, and I don't know if you were there, Danielle, we at St. Thomas Health 2 years ago had a lung cancer awareness ball game event. And in the past, we have had 12 survivors walk on the field. They're recognized. And it was easy to find 12 survivors. People were begging, can I be recognized? Can I be recognized? It was a struggle to get 6 survivors last year and co-survivors to be recognized on the field. And this year, it was equally as hard.
We'll do it for you. We'll get
so
them there.
my goal is to have 12.
We'll get them there.
12.
We'll send you 20.
I encourage you to go back to what NFL teams are here. Oakland and
Are you asking where the
49ers,
San Francisco 49ers are?
49ers and Oakland and let's see.
That's it for right here.
That's it from around here.
Really, it's just
You
the
got
Niners. But
San Diego and all that down there.
And those darn Raiders.
I mean, if you all know, well, I think the goal is to reach out to the hospitals that are partners with those NFL teams. And they're the ones that have those contracts, because that's how we did it. We worked with each other. And we were able to do that. We thought we would try to reach the audience there. And we even thought about putting a CT screening at the last event, but it wasn't worked out in time. So, and two, you need to let people know that it's there. You can't just put it there. But
interesting.
It'll open some doors and get some media attention.
It'd be very cool. Okay, so now it's all just kind of us chatting. So I want to thank you, everybody. Thank you for coming. Thank you for participating, everybody here in the room, and yet again, everybody online. We say all the time it's our most favorite day of the month. In November, it competes with most other days, especially the gala and, well, your birthday. Right. Those are our most favorite days in November. But thank you, all of you. And there's still plenty of food. If you came in late and you didn't get to eat, we have a microwave. We can heat it up. And there's plenty of wine and water. So mingle, and that's it. You're welcome. Oh my God! Did I thank you already? Did we already clap for you?
Yes, you did.
Are you sure?
Yes.
Please clap extra for Kimberly.
Thank you.